The second case, it's a patient with a right lower quadrant cyst. So I'm going to try to do what Arthi does and just pull it up as I go. The patient had right upper quadrant pain and had an ultrasound done. This is what the ultrasound showed. Let's see. So there's this complex cystic mass in the right abdomen with layering echogenicity. And there's these punctate echogenic foci along the edges. So then there was no flow inside it, or nothing that we can appreciate. But ultrasound, it has a very limited field of view. So anything that's large should really get additional cross-sectional imaging. So the patient got a CT abdomen and pelvis, and so this is what the CT abdomen and pelvis showed. It's just a post only. So we, gave a combination of benign and malignant differential diagnosis. So then the patient went on to get an MRI, which is what I read. So we see this sort of complex cystic mass in the right abdomen. It's not really, it's sort of abutting and displacing the adjacent small bowel, and there are these little, nodularity along the margin. So I gave a very broad differential diagnosis. Here's the just a little bit of motion to show you. I didn't see any appreciable contrast enhancement in the nodules, but I'm going to show you the images. So, that's a good question. I don't remember. Maybe we can find it. Mucocele was raised as a DDX, but I don't remember if I saw the appendix or not. So I think this is the TI. Is it the TI? Okay. The patient got resected, and it wasn't an appendix, but I don't see an appendix either. I don't know if you guys do or not. But so my question was, I thought this was benign looking and chronic in appearance because of the calcifications along the wall. But would you guys feel confident, say, to not? I mean, at what point can we tell them this patient does not need surgery? Because I didn't have that confidence, and so I was favoring a benign etiology. But in my DDX, I also said, a cystic mass, like a malignant lesion, is also something that I didn't favor as highly, but also in the DDX. Yeah. I couldn't tell what it was arising from. Do you? Can you? Oh, okay, let me go back. Mm-hmm. So it sounds like on MRI you didn't see any definite enhancing component? No. But the MRI was it was okay. It wasn't the most beautiful. So then this patient went on to get it resected. So this is what I said. I thought it was chronic and sort of benignish. But then I felt kind of like a wuss, and I said, well, it could also be a cystic neoplasm. So the patient went on to get an in-block resection, a right hemicolectomy, terminal ileal resection, and that mass resection. It came back benign. And they said it was a degenerating epithelial line cyst. They couldn't subtype the cyst. No cancer seen. So then there's is really great radiographics paper. It's a little old, but they divided in. There's 4 separate linings that they stratify these cysts by: mesenteric omental cyst, It's endothelial, epithelial, mesothelial, and other. Our pathologist couldn't subtype it, but if it's endothelial, then it's a lymphangioma. Enteric lining, then you think about an enteric duplication cyst. And these have a double muscle layer lining, and I'll show you an example that was shown in that radiographics paper. An enteric cyst, which has an enteric lining without the double muscle lining, and a mesothelial cyst, and a non-pancreatic cyst. These are all benign. The most common, if you're going to list in your differential diagnosis, is lymphangioma, a non-pancreatic cyst, and the other ones are not as common as those two. So this other paper sort of classified it based on complexity. So in this case, this is the double lining that they were talking about before that we see with duplication cysts. So you get this anechoic, you get the cyst, there's an echogenic inner mucosal layer and a hypoechoic muscular layer. So the inner layer is here, and then the muscular layer is that hypoechoic lining. So if you see that, then you can call it duplication cyst. I would be very impressed if people call that prospectively, but maybe that's what pediatric radiologists do well. In contrast, a mesothelial cyst, it's just a single thin wall with no solid components. So here it's a very simple appearing a large cyst. And then lymphangioma, on the other hand, are complex. So here's an example of a lymphangioma. They can have septations. They're usually no solid components, but these little what do I say? So, anyways, they're minimally complex. In contrast to, say, a mesothelial mesenteric cyst. So we don't know what this case was because they couldn't really subtype it. But I don't know. I felt bad because I didn't have the confidence to say it was benign, so that the patient could be saved the operation. But at the same time, I don't know that anyone would do that with high level of confidence. I don't know.
I don't think you should feel that bad. We were all thinking if we had a cyst like that in us, we want it out. And I had a similar case, and it was actually an endometrial neoplasm with a tiny focus of adenocarcinoma.
Oh, wow.
I think those cases you can't just, they have to eventually take them out.
Okay, that makes me feel better.